for a couple of days with the family. So when you see people get like 25 years, it's quite overwhelming. I went to several meetings in the US and then joined MASA back in July. When you see everyone, not wedding, people you haven't seen for a long time, all the relatives are all in one place. All the beautiful people, all the people you love and care for here. So I'm just really honored to be a part of Class 90. I'm very, very proud that we're back here after 25 years. And thank you for sharing this time with us. So anyway, pediatric immunization is such a big topic. Some people dedicate their entire lives just studying a particular component of a vaccine. So they asked me to talk about pediatric immunizations. It's like, what do I talk about? So what I'm going to do is limit my talk to current updates. So anything that's new from late 2014 onward. And all of the data, all of the information that we're going to hear are based on the American Academy of Pediatrics recommendations and the Advisory Committee in Immunization Practices. I was looking through some of the immunization data or some of the schedules here in the Philippines. It kind of varies, so I told myself I'm just going to stick to what the EAP is recommending so you can get an overview of how vaccine schedules are made. So we follow a table depending on what the new recommendations are. There have been some changes about scheduling, some changes about the particular brand of some vaccines. That's what I'm going to talk about. Okay, so the main objectives of my talk will be to review the key vaccines that are essential for prevention and spread of the most common and serious infections in children and adolescents. Specifically, I'm going to touch a little bit of influenza, MMR. I'm going to skip rotavirus because we don't really see rotavirus here, varicella, and human papillomavirus. Most of these diseases, because of the advances in the technology of vaccination, can be eliminated actually or reduced with the use of highly effective vaccines. So influenza, first Lena or pollen or what's the rate of influenza here in children? Ballpark. You see much? Anyways, so this is the time of the year when we're seeing flu in the US. So it depends on the geographic region. The colder regions get hit first. So Northeast, Upper Midwest, they're already seeing the flu as early as October, all the way to March or April. Where I live in South Texas, the flu comes in a little bit later. So usually it starts around this time, after Christmas, and then peaks in about January, and then kind of lingers until February, March, April. So in the US, our goal is to manufacture the current influenza vaccination around the summer of that particular year, and the components are based on the strains from the previous year. People who manufacture the flu vaccine try their very best to match the previous year's serologies, but it's not always 100%. Where I practice, I've seen a lot of devastating effects of the flu, clinical illness, and perfectly healthy children can be well one day and be intubated the next day. So it's a very serious illness. Back in the 1990s, influenza vaccine trials showed a 20% one-year attack rate in laboratory cultures of unvaccinated children. So any children who are aged 1 or less have about a 20% chance of contracting a flu-like illness, and about 40% actually have culturally fluid influenza. So you can imagine half of young infants can probably be affected by the flu. And as such, because of the severe morbidity of influenza, a lot of infants end up being hospitalized and develop secondary bacterial infections, most notably from Staph aureus or pneumococcus, and develop pneumonia, bronchitis, sometimes sepsis and meningitis as an aftermath. So the Advisory Council on Immunization Practice recommends vaccination in the US for all children 6 months and older. So what I'm going to emphasize right now is that over the last 2 to 3 years, there has been a major change in the development of the flu vaccine. Currently, we already have two components of the influenza B virus. Previously, we had a trivalent with two components of the A and one component of the B. As such, the protective rate would range anywhere from 50, maybe at the most 80%. But with the addition of a second B component, the protection rate has increased to up to 80 to 90%. And this is actually the first year in the US that they've had a rollout of a quadrivalent inactivated flu vaccine. They did this because they found in previous studies that influenza B infection can also cause significant disease. Previously, they would say that all of the severe cases are probably attributable to influenza A, but with the advent of molecular technology, they have been seeing more and more B cases, and some of them actually cause deaths. So because of this, the emergence of a second lineage influenza B virus, people have already incorporated the two components of the B virus in the vaccine. Pretty much in the past decade, 25% of all influenza illness was caused by the flu B, so that's a big number. And the majority of influenza A was H3N2. H stands for hemagglutinin, and N is for neuraminidase, which are your two disease-provoking components of the virus. With H1N1 being unlikely or less likely, with the exception of 2009 pandemic year and in 2013, which 2009 virus resurged. So, technically, the two components of the B are called Victoria and Yamagata, and obviously, we coined the names from the region where the virus was first isolated. So currently, we're trying to phase out the trivalent vaccine. The health department is just finishing the doses that have been already dispensed, and from now on, it's all going to be quadrivalent flu vaccine. The third paragraph just tells you pretty much what's incorporated in the current 2015-2016 seasonal influenza vaccine. So again, as I said, H3N2, H1N1, B Victoria, and B Yamagata. Okay, so as I previously mentioned, because of the high attack rate of flu in young infants, all children are now being advised to receive the flu shot if they're 6 months or older. And this can be administered with your 6-month vaccine. So there's no need to deliver the vaccine separately from your hip or DTaP and all that. This is the only vaccine that is approved for children less than 2 years because the immunogenicity of the live vaccine is suboptimal in these babies. So if a child is 9 years of age and has never received influenza vaccine in his lifetime, we do a dose priming. So we give the first dose of the inactivated flu vaccine, and a month later, we give a second dose, and that is to enhance the serologic response to the vaccine. And then subsequently, in the following years, all we need to do is one vaccine. We've also been trying to advocate, at least the health department has been trying to advocate the pruning of infants who are not yet ready or who don't fall into the category of vaccination, namely children who are 6 months or younger. And what we try to advise healthcare providers is to vaccinate the household members as well, including parents and the school-age children who are most likely to carry the infection from their schools or work environment to the home. And again, in the United States, I have to ask, when do you do flu vaccine in pregnant women? All pregnant women. Okay, good. Because this is indicated for all pregnant women in the United States. And every year, anytime you get pregnant, if you fall within the flu season, you get an influenza vaccine. Okay, so now we're going to talk about the live attenuated influenza vaccine, which we call flu mist. It's an inhaled vaccine. It's a spray, and it's delivered through the nose. kind of concentrates in your bronchial tree and is responsible for an almost immediate immunologic response. As I mentioned, the quadrivalent form is available, only given intranasally. Some contraindications that the AAB has recommended is any patient with severe allergic reaction to any component of the vaccine, including egg protein, and concomitant use of aspirin due to the possibility of Ray's syndrome or aspirin-containing medications. These vaccines are also obviously not indicated for administration to pregnant women due to the risk of developing an active infection during pregnancy. So this is a very interesting graph because it shows you the attack rate of culture-positive influenza disease in children vaccinated with either your, then the trivalent inactivated vaccine or your live vaccine. And you can see the red graph represents your live vaccine, and the black graph represents the inactivated vaccine. And you can see that the amount of protection offered by the live vaccine is significantly higher than if you just got the inactivated vaccine. So this is actually recommended more for children. In summary, the broader and more complete immune response for your live vaccine is primarily due to the secretion of your IgA in your local bronchial tree, which is where influenza virus attacks, and also because of cellular immunity, which you do not get from your inactivated vaccine, which only offers humoral immunity. Also, the breadth and the duration of response to the live vaccine is more enhanced compared to the inactivated vaccine. So what are the take-home messages on influenza vaccination? Number one, very important, everyone 6 months and older should receive an annual influenza vaccine, and if possible, the quadrivalent vaccine. Those who are less than 2 years of age should be given the quadrivalent inactivated vaccine, and those who have not been primed should get 2 doses a month apart. Any child who's over 2 years of age without any severe asthma or general heart disease is advised to get the live vaccine instead of the inactivated vaccine. And there is a strong positive recommendation by the healthcare provider to reinforce vaccination of household members, especially of those infants who are 6 months or under. Okay, so now we're going to switch to HPV immunizations, which has had a lot of tremendous improvements or technology in terms of prevention and actual eradication of the HPV virus. So human papillomaviruses are small and double-stranded DNA viruses that actually attach to specific tissues in the body. And this occurs in all vertebrates. So from chimpanzees, monkeys, and all vertebral animals can actually get HPV. They are classified according to their tropism for either keratinized skin or mucous membranes. Those that are associated with mucous membrane infections are further subclassified as either high risk or low risk according to their proclivity for causing malignant transformation of epithelial cells. As you all know, the presence of HPV in a woman's cervix or vagina is a high risk factor for cervical dysplasia or malignancy. Also, HPVs chronically infect the skin, as what you see in warts, and the mucous membranes of the respiratory and anogenital tract. So this is kind of like a good table to show you how wonderful or how it's possible to probably eradicate all cervical cancers just by giving a woman a 6 or actually we have 4 and then 2 and then recently 9. But if you cover all of the cancer-causing serotypes, primarily 16 and 18, the chances of preventing cervical cancer in a woman who's never contracted HPV infection is almost 100%. So when they actually did the preliminary vaccine studies in this women, they had to abort the study early because the effect was just very profound. pretty much when they did the ACT trials in perinatal HIV. Again, it's high protection for vaginal cancers, not just much for vulvar cancers, and for males, which is actually very important. Initially, this vaccine was only approved for female adolescents, but as further studies went on, you could see the significant amount of protection that you can get from anal cancers in both sexes, penile cancers, and also head and neck cancers. So now the recommendation is to give this vaccine in university to all adolescents 11 to 12 and older. Again, you could see here which serotypes are responsible for causing cervical, vaginal, vulvar, and anal cancers, and the amount of protection of the vaccines. It's really very remarkable. This slide pretty much shows you the degree of prevention in HPV-associated conditions due to vaccine type HPV. So your chances of preventing the development of genital warts is almost 100%. So it's really remarkable. So the thing is, the key is actually to give this vaccine before a child becomes sexually active, because in most studies in the US, by the time they're 15, about 30 to 50% of the females have already seroconverted to HPV. By the age of 17, 18, almost about 75 to 80% of teenagers are already HPV positive. So you want to give this before the child even engages in sexual activity. So current recommendation of ACIs, immunization of girls aged 11 to 12, but girls as young as 9 years old may be vaccinated. So previously there are only two types of vaccines, the 2 and the 4 valent. There's a new 9-valent vaccine which is now being given, and we're actually already phasing out the other 2 types. So they're not manufacturing the previous types of vaccine anymore. Of note, only the quadrivalent and the 9-valent may be given to boys, because as you recall, the bivalent only is protective against serotype 16 and 18, which causes cervical cancer but not anal or penile cancers. So you don't need to, or giving the bivalent vaccine to males is not really protective. Major setbacks. I don't know about here, but in the US there's been some kind of resistance in giving, or in patients or in parents in terms of acceptance of this vaccine, because typically when you tell them, or when a healthcare provider tells them that you're giving a vaccine to a child to prevent a sexually transmitted disease, they become very defensive. So they tell you, oh, there's no way my child is going to have sex. No way. So you already, it has a negative connotation whenever you present the vaccine in such a manner. So what the American Academy of Pediatrics is recommending is just to keep your conversations about the vaccine short and simple, treat it like any other vaccine. So you just tell the parent, your child is 12 years old, it's time to get the meningococcal vaccine, the DTaP, and the HPV vaccine. That's it. So you don't expound unless they ask specific questions. One other thing that some researchers advocate is to evaluate patients for risk factors. Obviously, men who have sex with men, or those who are promiscuous at a young age, less than 11 or 12, should probably be given priority in receiving this vaccine. And as I mentioned, this is already included in your vaccination table, so it should be given concurrently with your Tdap and meningococcal vaccines. Now we switch to MMR and MMRV, varicella immunization quickly. We all know how devastating a true measles virus infection can be. It's a very, very contagious infection with a 90% infectivity rate. So if 10 people happen to be in the same room with a patient with measles, 9 out of 10 people will get that infection. So it's really significant. And we've done a pretty good job in giving MMR, and most lately varicella, but over the last couple of years there have been some setbacks. As you all know, it was advertised pretty much universally that there was an outbreak of measles in Disneyland, LA, California, sometime between December of last year and February of this year, and they identified 125 cases. So these are all new cases. When they did blood tests on these infected children, 45% of those who got illness were immunized, and about 43% had an unknown status. So this could have been an easily preventable occurrence had 90% of these children been vaccinated. So vaccination is very effective. If you give 2 doses, there's 95 to 90 protection against illness. Now, what do we do with patients with HIV? So we have been looking at this from the very beginning, since the 70s and 80s, at the onset of highly active antiretroviral therapy. And most studies have shown that the immune response of MMR of children who are HIV positive to MMR is suboptimal and not long-lived, and that's because of their suboptimal immune status. Patients who receive highly active antiretroviral therapy did not improve their MMR positivity, and they actually had to be given more than 2 doses, sometimes 3, 4, 5 doses to achieve a serological response and more. Children who were born to HIV positive patients who did not get AZT or Niviral prophylaxis exhibited low rates of immunity to measles compared to HIV exposed children. So those who were positive at birth had a lower immune response compared to those who were just exposed to mom who was HIV positive but did not turn out to have HIV. And the same pattern was seen with your mom's vaccine and rubella. Now, the most current change, I would say within the last 1 to 2 years, is because we are now very aggressive in treating children with perinatally acquired HIV with multiple drugs, and most of the time we achieve a 0 viral count within several months, and there's no detectable illness. Some researchers have actually advocated giving all the live vaccines to these children according to your routine immunization schedule. So if they turn 1 and their HIV PCR count is no virus detected, and they're clinically asymptomatic, you go ahead and give them the MMR at 1 year age. So that's something that's new, because before all live vaccines were contraindicated in any HIV patient, regardless of clinical or serologic status. Now, if MMR vaccines are administered before you start giving the child antiretroviral therapy, 2 additional doses of the vaccine separated by 28 days after initiation of your heart for at least 3 months should be administered. So you give 1 dose, and then you give the heart, and then a month or so after you start treatment, you give 2 additional doses. So that's what I meant by them needing more than additional regular 2 doses. Sometimes you need 3 or 4. However, the MMRV vaccine, or the one with the varicella component, also the Varivax, is still contraindicated in children with HIV infection. Now, what are the barriers that we've been encountering recently towards MMR immunization? Welcome to Google University. The parents are able to read a lot of information, a lot of blogs, and thank you to Jenny McCarthy and Andrew Wakefield. They've kind of like caused this brouhaha about pretty much all vaccines, but particularly the MMR vaccine as a major risk factor for getting autism spectrum disorder. Now we all know that those studies have already been debunked, but the stigma that's been associated with that vaccine is lingered. So we still have a lot of parents, especially in the West Coast and LA area, who are into this holistic medicine, who are really against immunizing their children. There was a recent article a year ago in Pediatrics, 2014. It was a Hendrix study, and about 802 children were enrolled in the study. The control group was only given, your vaccine information sheet. You can only get a vaccine. They give you this information sheet that tells you roughly what the side effects, and you sign, you can send you the vaccine. So that was the control group, and the clinical group was they were given the VIs, the vaccine information sheet, but at the same time were also counseled in terms of the clinical and social benefits of MMR vaccination. And they found out that those who just got the paper without any explanation had a lower response rate or acceptance rate to the vaccine versus those that got both some clinical and social information. Clinically, they tell you, okay, this is what measles can do. About 90% of individuals can be affected if you're exposed and unprotected. A lot of the kids can develop secondary bacterial pneumonia, sepsis. It could cause severe morbidity in your child. Social benefits would be like, okay, your child's probably going to have a hard time in school. Some parents may not want to have their children associate with your child because if your child gets infected, they don't want their children infected. So when you start talking to parents in that realm, they start to be more receptive to vaccination, regardless of whether it's MMR or some other vaccine. Now I'm going to just talk briefly, this is going to be my last topic, about serogroup B meningococcal vaccines in persons of increased risk. Previously, we only had one kind of meningococcal vaccine, and that was given to children 11 to 12 years, those with complement deficiency, those who were asthenic, military personnel, some prisoners, so a very specific population. So your current quadrivalent conjugate vaccine is recommended, as I mentioned, for people with complement component deficiencies, those with anatomic or functional asthenia, those microbiologists who routinely are exposed to isolates of Neisseria meningitidis because it's a airborne infection, those who are exposed to community outbreaks, those who reside in countries in which the disease is hyperendemic or epidemic, dorm kids or first-year college kids who are going to be living in residence halls, and some military recruits. Within the last couple of years, there have been 2 meningococcal B vaccines. Remember, your quadrivalent vaccine had your ACYB components. Now there's this new meningococcal B 2-component vaccine. And it's a 3-dose series, pretty much given like your hepatitis B and your human papillomavirus vaccine, so 0 to 6. And again, it has a component of subfamily A and subfamily B, and was just licensed in the United States about a little over a year ago, in October of 2014. That vaccine is called Tromenda and is distributed by Pfizer. A newer vaccine was just marketed earlier this year in January, and it's called Bexero, distributed by Novartis.